LVF is left ventricular failure. This is your classic CHFer, okay? Our CHFer, we got here this woman who short of breath, she's tachypnic, she's got edema, we got pedal edema, I got hypertension, so all my blood pressure's systolic is almost 200. I got PND. Whoa, what is that? Paroxysmal nocturnal dyspnea. Paroxysmal nocturnal dyspnea. This is PND. PND is found when your patients have an acute onset of shortness of breath when sleeping. So if somebody's laying down and they're trying to go to bed and all of a sudden they get short of breath and they have to sit up and this is why a lot of these patients that have CHF, they have to sit up in a recliner when they try to sleep because they have paroxysmal nocturnal dyspnea. Treatment, we said CPAP, right? What's the goal here? The goal with LVF is to create PEEP. PEEP stands for positive end expiratory pressure. Remember, we can start at 5, we can work our way up to 10 PEEP. And what we're trying to do is not only push that fluid out of our lungs, but we're also trying to maintain those alveolar sacs open to allow for gas exchange. Once there's a lot of pulmonary edema that's inside of these bronchioles, it causes basically the surfactant around those alveoli to kind of get washed out, and atelectasis occurs. We get alveoli that collapse. By providing PEEP, it pops those alveoli back open, allows for diffusion, allows for there to be oxygen that gets into that patient, and CPAP is awesome. Now, you got to know when you can't use CPAP. We can't just throw CPAP on anybody, right? Patient has to have a good blood pressure, and they have to be able to be coached. So they have to be able to follow your commands. Next one, nitroglycerin. We give nitroglycerin to reduce preload. Remember we were talking about the use of nitroglycerin for heart attacks? We are using nitroglycerin there, not only to reduce preload, but we're also using it to open the blood vessels to allow more blood get into the heart. We're not having a blood getting into the heart problem right now with heart failure. What's our problem? Our heart is failing. Our heart is dying, okay? It's working too hard as it is. So what we do with nitro is we reduce preload to basically take off the pressure and take off the stress off of the heart. Help that heart reduce its oxygen demand. Can we give diuretics? Diuretics are still a part of CHF protocol. It is, okay? I'm not going to tell you it's not, but what I will tell you is that it's no longer indicated for EMS. Per the national standard. Per national standards, Lasix or furosemide is no longer indicated for EMS because EMS has a hard time in determining is it CHF or is it pneumonia. Not all pneumonia patients have a fever. Also, we don't know if patients are really dehydrated, and we don't know exactly what's causing their rales or their crackles or their pulmonary edema. This is why a lot of departments, a lot of agencies started pulling Lasix off of their trucks, and the national textbooks for EMS and for paramedics no longer states that paramedics should be giving Lasix in the pre-hospital setting. Exactly right. We don't have labs to determine if that patient is experiencing some sort of infection. We just don't know. But is it still in the CHF protocol? Yes, it is. If your patient is suffering from left ventricular failure, and you know it is left ventricular failure, Lasix is still indicated. Right ventricular failure, RVF, signs and symptoms, a little bit similar. And the reason why they're similar is because left-sided heart failure causes right-sided heart failure. Typically, when you have a patient with LVF, your patient will also show signs of RVF. A patient with right ventricular failure, you're going to see the edema, okay? The pedal edema, classic. Another one that you see if the patient just has right ventricular failure is hypotension. Hypotension is a classic finding for right ventricular failure. Now you might say, why? Why is there low blood pressure in right ventricular failure and not with left ventricular failure? The reason being is that with right ventricular failure, if your patient's suffering from just right-sided heart failure, remember on the right side, that's where preload starts, okay? If you have a failure of the right side, you're going to have a decrease in preload. By decreasing preload, you will decrease cardiac output, and by decreasing cardiac output, you're going to lower the patient's blood pressure. Classic finding number 3, JVD, jugular vein distension. How do we assess for JVD? 45 degrees, semi-Fowler. I'm going to repeat that. How do we check for JVD? 45 degrees or semi-Fowlers, okay? By definition, semi-Fowlers, 45 degrees. Always a test question regarding something to do with JVD. Very easy to make a test question out of right-sided heart failure. Just remember, you're looking for those 3 symptoms. Now, what is our treatment? We're going to consider fluids and pressors. I'm going to withhold those fluids if my patient has rails, okay? So if I see signs of RVF, I'm going to be like, oh, this patient's got the JVD, we got pedal edema, and if I listen to lung sounds, my patient has rails, I am not going to give that patient any fluids. Now, some of you might say, well, you can give a little bit of fluids because the textbook says so, and it's true. The textbook says you can give up to 200 mLs of saline to see if there's any change in the patient's breathing status. That sounds super safe, but that is how textbooks are written. Fluids and pressors are the treatment for right ventricular failure. Now to talk about cor pulmonale, since we're talking about heart dysfunction, cor pulmonale is pulmonary hypertension that occurs from COPD. It says it's a disorder in which pressure in the pulmonary arteries is higher than normal. The right ventricle must work hard to overcome increased resistance. The right ventricle enlarges and the right side of the heart will eventually fail. Because you got to remember, where's that right ventricle pumping to? Pulmonary circulation. And if the circulation within the pulmonary system is high in pressure, the right side has to work harder to get that blood in. And by doing so, this causes right ventricular failure, known as cor pulmonale. Classic type of test question as well. To sum up heart failure, if your patient is suffering from, let's say they have rails, looks like a CHF patient, you see the edema, you might even see the JVD, whatever the case might is, the patient looks weak, maybe diaphoretic, you put on a blood pressure cuff and they have a low blood pressure. And you're like, whoa, this patient has fluid in their lungs, but their blood pressure is low. We're looking at a cardiogenic shock patient, right? This patient has a pump problem. Their blood pressure is not low because there's a problem with widespread vasodilation, or their blood pressure is not low because there's any other issues other than the pump sucks, man. The pump is not doing its job. And if the pump's not doing its job, then your patient's heart is failing, and we call that cardiogenic shock. How do we fix it? Pressors. We have to make the heart work harder. Unfortunately, this heart's failing and it's going to cause your patient to go into cardiac arrest. This patient needs to go to a hospital ASAP. But for us to stabilize this patient and get them to the hospital, we need to utilize pressors to maintain cardiac output so we can get to the hospital. That's it. With that being said, talking about pressors, what blood pressure am I trying to obtain? What systolic pressure am I trying to obtain by giving pressors to any patient more than 90? My systolic has to be above 90 at all times. That's how it's written. If at any time it falls below 90, we need to turn on the pressor. Now, this is where there's nothing set in stone. Like, let's say that you have dopamine flowing on this patient with cardiogenic shock, and oh, we got a blood pressure now of 94/50. Well, I'm above 90. Do I shut it down? Do I keep it going? There's nothing in writing to say, oh, you have to get to 120. How it's written is you cannot fall below 90. So it's safe to say that we can go up, and I would want my patient to get closer to 110, 120 before I decide to shut it down, right? We call that titrating to effect. I would want to titrate my patient's blood pressure to a place where it's stable, but I don't want to be too high. Because remember, I don't want to cause too much pressure. I don't want to make that heart work too hard. I'm going to make it go to a place where I would consider it normal. Remember, a normal map is 65. We want to get anywhere between 60 to 65 on a map. How test questions are typically written, though, is that we're watching for a systolic greater than 90.